Okay, sir, I am presented with the X-ray skull frontal projection, in which I can appreciate that there is haziness noted in the left maxillary sinus, and the inferior orbital floor is also somewhat ill-defined. So I would now examine rest of the bones, which are grossly unremarkable. So I'm concerning of for a fracture infraorbital floor of the fracture infraorbital floor with the extension into the maxillary sinus. I would advise. I would refer the patient to the maxillofacial surgeon for further
Good.
management and workup and advise CT if clinically indicated.
Good, yeah, boss. Good, yeah, boss. Yes, as you said, it's a plain radiograph of the skull PA view, showing the two main findings here: indistinct left inferior orbital rim with soft tissue just يعني below it. Impressive of the name of this sign because they love the signs.
Sir, teardrop sign.
Yes, teardrop sign with air fluid level within the left maxillary sinus, impressive of hemo sinus. No other definite fractures, although يعني we are suspecting some fracture here, but not definite. No other definite skull fractures could be seen. Diagnosis findings are those of, and also you can exclude no air lucency within the left orbit. Findings are suggestive of left orbital floor fracture or blowout fracture. Urgent referral to maxillofacial team, and also recommend CT scan of the face with 3D reconstruction. Very good, Yunus. What about the same? What about the next case?
Okay, sir, I'm provided with the OPG view uh, of a patient, and in this I can appreciate that
History may be helpful. Left jaw pain.
left jaw pain. Sir, the TMJ, yes, sir. So there is dislocation of the left
Yes.
TMJ joint is noted, and
Yes.
the right temporomandibular joint is unremarkable. And I would now look for rest of the bones, condyles, and rest of the bone and the mandibles. They are unremarkable. So, sir, it's a left TMJ dislocation, and I would advise any other view if needed and refer the patient to maxillofacial surgeon for further management and workup.
Okay. Any specific imaging modality as a next step for TMG
Sir,
joint,
sir,
temporomandibular joint?
sir, open mouth views and
Actually, this is one of the description. I'll tell you in a minute. Okay.
okay.
MRI, temporomandibular joint may be
MRI
advised
tomography. Yeah.
to
Okay.
assess the disc and its integrity. So, as
Okay.
you said, yeah, boss, the left mandibular condyle is dislocating, having empty fossa, together with some malalignment, okay, of the teeth. The teeth is not properly aligned, the upper row and the lower row. And the patient
Okay.
is imaged in open mouth, which is
Okay.
unusual for this radiograph. This radiograph is called orthopantomogram. So abnormal mandibular condyle, abnormal alignment of the teeth, open mouth, no definite fractures could be seen. Findings are suggestive of left temporomandibular joint dislocation.
Location.
I'd or referral to oral and maxillofacial team, and mandibular or MRI temporomandibular joint is advised.
Yes.
Next case, trauma.
Okay, okay, sir. I'm provided with the X-ray skull lateral view in which I can appreciate that there are multiple well-defined to ill-defined lucent lesions noted throughout the skull bone, and there is no definite cortical break that can be appreciated. Mandible also shows some lucencies, but mandible is grossly unremarkable. So is the visualized upper vertebral
It's
body.
okay. Maybe similar smaller
Yes, a
rounded
similar.
lucency
Yes,
may be seen
uh,
also, and I'm
also.
suspecting also along the spine. Okay.
along the spine as well. So, sir, I would like to review them on orthogonal view if available. So, I'm
Good.
concerning for some with differentials of multiple myeloma and METs. I would advise correlation with the previous radiograph if available, and I would advise low dose CT scan of the whole body and correlation with Benz-Jones proteins for further workup and further management, and refer the patient to oncology for further workup.
Very good, very good, very good. It's a case of multiple myeloma. It's classic. As you said, we have a plain skull radiograph lateral view. So one of the recommendations, review the other views. Very good. And as you said, multiple small lytic lesions disseminated all over the examined bones, particularly in the skull. No definite fracture or anything else, or soft tissue abnormality. Findings are suggestive of aggressive bony lesions like multiple myeloma. Recommendations, as you said, low dose whole body CT scan or whole body MRI in
MRI.
UK. It's accepted nowadays. Regarding the test, as you said, serum and urine protein electrophoresis. Very good, yes. Okay, and the differential metastasis, as you said.
Yes, sir.
Okay, important case. 2 year, or let's say 1 year, okay, child fall from bed on the head.
Okay, sir. I'm provided with the X-ray of a 2-year-old child, lateral projection, with a history of fall. I can appreciate that there is fracture noted along the parietal bone. I would like to review the orthogonal image if available, and I would also take the history of the patient to rule out any suspected non-accidental injury, and I would
Why
refer the
you
patient.
suspecting this? Because
Sir, because it's a unusual fracture
yes, yes, and the given history is not consistent with the severity of the skull fracture.
of the skull fracture. Yes, sir.
Yes, it's
Yes,
a
yes.
complex, multiple branching skull fracture
Branching
with
skull fracture
significant widening as well. It's not consistent with this given history.
with
Just
the
a
given.
fall from bed.
Yes,
Okay,
sir.
very good, very good. So what you will do next?
Sir, I would, sir, call the, sir, I would suspect the non-accidental injuries. I would, if there is suspicion, I would report the case to the social services and advise schedule survey, and also CT brain if clinically indicated.
Yes, yes, very good, Yps, very good. The history here is not consistent. Okay, suture is also dilated. And sutures is also dilated like the coronal. And this is a
Yes.
multiple
Multiple branching
fractures.
fracture of the
Yes.
parietal bone.
Yes, with some soft tissue edema, likely subgaleal hematoma as well. No other abnormality could be seen. Findings are suggestive or highly suggestive of non-accidental injury. The other name, suspected physical abuse. It's a rather new name. Uh, Immediately call or phone the pediatric physician, and immediately call also child protective service in the hospital. Okay, then ask for a skeletal survey and urgent CT brain. Very good, yeah, boss. What about again?
Okay, sir, I'm provided with the
Just a minute,
X-ray.
just a minute.
Sorry,
No
sorry.
problem. I will repeat. We will call to يعني two directions: the referring physician, especially pediatrician, and child protective service, the officer, security of the hospital, to keep this child in radiology department. It's an important step. So two phone calls must be done. And two imaging modalities must be done. Skeletal survey, all bones should be imaged, and CT brain. In this case, urgent CT brain. It's mandatory in such case, because one of the commonest findings in non-accidental injury is not just a fracture, subdural hematoma. Okay. This يعني I think it will be enough يعني in case of child abuse. Okay. 70
Okay,
years right hip pain.
Okay, so I'm provided with the X-ray pelvis frontal projection of a 70-year-old male patient. I can appreciate that there are tiny metallic lucences noted in the expected site of the prostate gland, and I would also examine rest of the bone, which shows mixed sclerotic lesions, which seen throughout the skeleton, diffusely involving the skeleton. Sir, I would like to correlate my finding with the history of the patient. I would inquire if there is having any history of prostatic carcinoma, and I would review the previous record of the patient. So this is likely these are likely diffuse sclerotic metastasis from a CA prostate, and I would if this is this must be some not the first finding.
It's
So
already
I would
known. It's already known because
already
of
known
this
case. So
treatment.
I
It's
have
a
yes, sir. Post
brachytherapy
brachy
seeds used
sees
for radiotherapy for the prostate local
targeted for
treatment.
radiotherapy of the prostate. Yes,
Yes.
sir.
So the case is already known as cancer prostate. So as you said, review other images, compare with other images as this most likely known case. But maybe this is a new finding, sclerotic metastasis. So we
Yes.
suggest a metastatic workup.
Mm.
Okay.
Bone scan workup. Yes.
Yes. Bone scan and CT CAT. Okay. Very good. Thank you, my friends who wrote the treatment. Thank you. Uh, well done. Okay,
Thank you, sir. Okay.
another case يا boss. 70 years acute abdominal pain.
Okay, sir. I'm provided with the X-ray abdomen frontal projection of a patient, in with the obvious abnormality I can see is that there are markedly distended bowel loops can be seen, and sir, keeping in view the pattern, this is likely small bowel dilatation. Also, I can appreciate that there is a dilated structure noted in the mid abdomen, and subtle air lucences can be seen in the rectal region. So this is a likely acute small bowel obstruction, and
Agreed.
also suspecting some cecal volvulus as well, as there is dilated structure in the mid abdomen. I would urgently pick up the phone, refer the patient to the surgical department, and meanwhile I will also advise CT abdomen for further workup and correlation of
So
the.
your diagnosis, small bowel obstruction
Yes, sir.
only,
No, sir. Cecal volvulus as well. I'm suspecting cecal
not
volvulus.
yeah, not classic for cecal volvulus. Anything else? Any complication?
Sir, liver, I would like to review any nematosis and gangrenous. Sir, these there I can appreciate that the both walls of the bowel can be appreciated. So
Yes.
pneumoperitoneum is also
Yes. You
yes,
are
yes.
cheating. They told you
No,
the
no, no, no,
answer.
sir. No, sir.
Okay, no one help Dr. Amir. Okay.
Yes.
Okay, I see the wall here. It's a regular sign. I can see the wall in multiple bowel loops, but here definitely it's regular. Here
Regular, yes.
maybe pseudo regular because gas in a bowel and gas in a bowel may cause visualization of the wall. It's called pseudo regular. But what about
Regular.
here? No bowel loop is found here. This is a free air. And this is
Yes.
air inside the wall. It's definite regular sign. Regular sign, it means perforation. So small bowel dilatation or obstruction complicated by perforation. It's an urgent case, need urgent surgical referral.
Surgery.
And of course, urgent CT scan is done to reveal the cause. Okay, يا boss. Take care. Take care. Maybe one case abdomen, but it will be emergency. Okay.
Yes. Yes.
We need to rule out emergencies in abdominal radiograph, like pneumoperitoneum or other causes, pneumoretroperitoneum, emphysematous pyelonephritis, emphysematous cystitis, urgent conditions. And take care also of underlying spine. You may see some hidden findings. Okay,
Okay.
يا boss. Neonate, abdominal distension.
Okay, sir. I'm presented with the X-ray frontal projection of a neonate presented with the abdominal distension, and sir, again can appreciate that are dilated bowel loops are noted, and sir, NG tube is seen, which is seen in C2, and I would now examine rest of the structures. I can appreciate that there are air lucencies noted along the right hemiabdomen, which are concerning for pneumoperitoneum. And sir, also
Yes.
yes, sir, yes, sir, here. And also the regular sign is also seems to be positive in this case as well. So I will
Okay.
urgently pick up the phone and refer the patient to the pediatric surgeon, convey the findings, and advise. So will we advise CT in this case too?
No, no, no,
Because
no, no.
it's
Urgent surgery. Urgent surgery.
okay, urgent
No need
surgical.
for CT.
Okay.
Okay, because what is the commonest cause in such in age group, in this age group?
So necrotizing
Yes, yes.
enterocolitis.
Actually, this is a preterm baby, by the way.
Yes.
But you said we have here abnormal lucency and we have a regular sign.
Sign both.
Okay. Mild or massive pneumoperitoneum?
Sir, I guess
I think
uh,
mild. Okay.
mild. Okay. Okay. So the
Yes or
football sign
no?
is not present.
Uh, so it's mild.
Sir, I think it's massive.
Why? Abdominal
Sir,
wall. Abdominal wall is opaque. Okay, good.
okay.
Liver should be opaque. What about here? You see this lucency?
Yes, sir. This is the ear tracking alongside the liver as well.
Yes, actually, it's a football sign, yeah,
Football
boss.
sign, yes, sir.
This
Yeah.
massive pneumoperitoneum. Okay, take care, because maybe this is the only sign. The liver opacity should be similar to the abdominal wall. Any difference in lucency reflecting a massive pneumoperitoneum. It's a football sign.
Okay, sir.
Other finding, plus or minus, some mottled gas lucency is present here because this is the underlying condition. You see these mottled lucencies?
Yes, sir.
It may reflect pneumatosis intestinalis, commonly
Mm.
present in the right lower quadrant. So this case, bowel dilatation, bowel perforation, most likely secondary to necrotizing enterocolitis for urgent surgical referral. Yes. A question for oral exam. How to judge a dilated small bowel without having any measurement tools?
Sir,
When to say this bowel is dilated?
say if it's more than the size of the vertebral body.
Yes, more than size of vertebral body height. This rule in adults, but in children, the vertebral body mostly formed of cartilage. How to judge bowel loop if dilated?
Mm.
I don't know. Little help. Okay. Good,
No, sir.
good. Yes. Interpedicular distance.
Okay.
Primary of L2, as I remember. Okay. Interpedicular
Perpendicular
distance. No
distance.
cartilage in this area. Unlike the vertebral body here and here, it's cartilaginous. So
Okay, sir.
this bowel loop is larger than interpedicular distance. It means it's dilated bowel loops. Okay, good, yeah, boss. Next
Okay.
case, trauma. Hmm.
Sir, okay, I'm presented with the X-ray cervical spine, a lateral projection of a 75-year-old female patient uh, presented with the history of trauma. Sir, I can see that there is, sir, at the atlantoaxial joint. I can appreciate that there is some. Sir, actually, it's a bit blurred image. So,
Film edge.
okay. So there is enterolisthesis of C2, 3, 4,
Yes,
5, T6 over C7. There is a grade 2 to 3 enterolisthesis of C6 over C7 is noted.
good.
I would like
More
to review
than
this
50%
50%. Yes.
antrolysis. Very good.
Yes.
And
And sir, prevertebral air
you
is
described this antrolysis, anterior displacement of C6 over
C7.
C7 bodies.
So this
What
is likely
else?
bilateral bilateral facet joint dislocation and
Yes,
inter.
this is a diagnosis. So malalignment of C6-7 facet joints as well. Sometimes
Yes.
we see fanning here. Sometimes we see widening of the disk space. So just
Yes.
remember this descriptive term. And sometimes we see some thickening of the prevertebra. which is not our case. Background of degeneration or spondylodegenerative changes, no fractures seen. Findings are suggestive of
Bilateral burst facets.
bilateral facet dislocation. Recommendation,
Sir, orthogonal view and refer the patient to orthopedic surgeon for further or spine
yes,
surgeon.
yes. And we advise CT plus or minus MRI because we
Yeah.
are expecting something in the cord.
Neural foramen, yes.
Yes,
Yeah.
yes, a neuronal compromise. Okay, sore throat.
Okay, sir. I'm presented with the X-ray skull lateral projection of a 45-year-old male who presented with sore throat. And in this, I can appreciate that there is, sir, sir, thickening of the epiglottis is noted.
Good,
Uh,
good.
and sir, also there is, yes, thickening around the hyoid bone. It can also be appreciated. And sir,
Also,
rest
thickening of this structure, which is
epiglottis, sir.
area epiglottic fold. So the
And
epiglottis and area epiglottic fold both
yes,
are thickened. What is
thickened.
being
Yes.
normal here?
Sir, airway, air,
Yes, subglottic airway is
subglottic
normal.
airway is normal.
So
Good,
it's
yeah.
not, sorry. Okay,
الله يعافيك.
okay. So subglottic airway is patent and normal, and also
Sir, due to
hypopharyngeal air column is
hypopharyngeal,
not distended.
not
These
distended.
are
Yes.
the findings seen in croup. Okay, normal bony structures. The findings are suggestive of
Crew, sir,
yes, yes, it's a croup.
crew or a
So
paper.
croup, it's a croup. Is it
Uh,
croup يا boss?
sir, epiglottitis.
Epiglottitis. Okay. Okay. Thickened again, no problem. Thickened epiglottis and airy epiglottic fold impressive of epiglottitis.
Yes, sir.
Normal tracheal air column and normal hypopharyngeal air column rule out any associated croup.
Crew, yes.
Okay. So it is not croup. In case of croup, this area is markedly narrowed. I will remove
Okay,
the annotation. This area will be markedly narrowed in case of croup because it's laryngeotracheobronchitis and normal epiglottis in such case.
okay, sir.
Okay,
Okay,
this
okay,
is
sir.
epiglottitis. So
Okay.
the diagnosis, epiglottitis management.
Sir, refer the patient to ENT surgeon for further workup and management.
Yes. And what about the next step? Is
Mm,
it tracheostomy as Dr. Mega wrote or no? It's
sir,
an emergency case.
airways. Okay, okay.
Intubation, immediate
Intubation.
intubation if
Intubation,
possible.
if
Immediate
possible.
intubation if possible. Sometimes
To
we
secure the
may
airway.
proceed. Yes. Sometimes we may proceed even to tracheostomy. Yes. So immediate intubation to keep the airway patent. Very good, yeah, boss. Last case, trauma.
Okay, sir. I'm presented with the X-ray of the lumbar spine, frontal and lateral projection, in which I can appreciate that there is a reduced height of L3 vertebral body is noted, and there is also a mild retrolisthesis of the
Good.
L3 vertebral body into the spinal canal can also be appreciated. And now spina bifida is also noted at the level of L5 and S1, and I would now examine rest of the bones, which appears to be grossly unremarkable. So I would convey my findings to the referring physician and advise MRI if MRI plus minus if clinically indicated.
CT MRI.
And
Okay, CT MRI because bony
CTM,
and neural compromise. As
neural
you said, the
compromise.
boss reduced vertebral height of C3, and there is a transverse fracture line is
That's
seen through
true.
the body and
Body of the
posterior elements, and also the transverse processes.
yes, sir.
Okay. Okay, with some expected يعني pre-vertebral, maybe pre-vertebral soft tissue shadow, but definitely there is a retro-pulsed bone
Bone
fragment is
fragment
noted. Okay, finding
central.
are suggestive of
Sir, fracture of L3 vertebral body, and it's likely
Do
a
you have a
chance
certain
fracture.
name?
It's a chance fracture.
Yes, it's a chance fracture. Very good, very good. Okay, so urgent recommendation and CT and MRI. MRI
MRI.
to assess the cord and its compromise, or the, I'm sorry, the thecal sac and nerves, and CT for the bones and for other structures. Like what?
Okay. Sir, CT to look for, sir, in pedicles and posterior elements and
Transverse or chance
transverse limb.
fracture maybe affect also some viscera. So CT will be helpful.
Sir, sir, if it
Like
is
what?
at the level of, if it is at the level of L1, then to look for pancreatic or associated duodenal injuries.
Very good, very good. Yes, yes, because it's commonly resulting from C-belt injury,
C-belt
C-belt
injury.
injury, pancreas, duodenum, mesentery, transverse colon, maybe also injured in this type of injury. Okay, thank you, boss. Well done, well done.
Thank you, sir. Thank you. Thank you.
Okay.